topic in the GIT series, and the name of the topic is Inflammatory Bowel Disease. As all these slides are taken from Dr. Prasad, I first acknowledge him and thank him for his presentation. We'll start with a case that let us consider that a 17-year-old male complains of pain in abdomen and history of passage of blood and mucus in his stool since 5 months. He also gives a history of spontaneous remissions. So with this history, first we think that there must be some infection, and because of that he must be having these kind of problems of infectivity as the cause in this case. So with that in mind, a stool examination is done, which shows presence of mucus, RBCs and pus cells. It is also negative for OA and parasites, and cultures done repeatedly, they come negative for pathogens. So there is no infection as such in this case, it is ruled out. Still the patient is having diarrhea, still the patient is having pain in the abdomen, and then the possible diagnosis here becomes a condition which is called as inflammatory bowel disease, IBD. So before going into this theory or what is the disease, we'll just see what is oral tolerance. So usually in the body, entry of pathogen is associated with the production of antibodies or activated lymphocytes, and then this is how inflammation occurs. So there is an inciting agent, pathogen. Inciting agent is pathogen. Once the pathogen enters the body, body reacts by production of antibodies and or activated lymphocyte and neutrophils. This is inflammation. Now oral cavity is a site, or the GI tract is a site where the bacteria are present normally in the body as commensals, in the sense that they do not provoke a inflammatory reaction. Lot of bacteria are present on our skin, in the oropharynx and in the large intestine. So with these pathogens do not produce inflammation, and it is said that body tolerates them. The reaction of our defense system against these normal commensals is inappropriate. So that is the concept of oral tolerance. So now we will see what is inflammatory bowel disease, and we define it as an immune mediated chronic inflammatory condition of the intestines. So it is basically, we have to understand that this is an immune mediated process, number one, and number two, it is a chronic process. So under this ambit of inflammatory bowel disease, two important conditions as undergraduate students you should always remember, and they are ulcerative colitis and Crohn's disease. Very important things to remember. As UG students, these two conditions you should remember. And in 15% of the patients, it becomes very difficult to differentiate ulcerative colitis from Crohn's disease. So they are called as cases of indeterminate colitis. So that is entity where one is not sure whether there is an ulcerative colitis or it is a Crohn's disease. So when we try to see the epidemiological differences in ulcerative and colitis and Crohn's disease, we will first see the differences and then go to pathology of each disease. So if you see the incidence of ulcerative colitis, So it is almost 2.2 to 14.3 per lakh, whereas Crohn's disease is similar, 3.1 to 14.6 per lakh. The age of onset of ulcerative colitis is similar to that of Crohn's, meaning by it occurs at the younger age and then at the older age, means 15 to 30 and then 60 to 80. The ethnicity for the disease is the same for ulcerative colitis and Crohn's disease. Male to female ratio is, in ulcerative colitis it is 1:1, whereas in case of Crohn's disease it is 1.1:1.8:1. Now here it is written very nicely that smoking may prevent the disease. I will tell you later on how it happens. Whereas in Crohn's it may cause disease. Oral contraceptive, the incidence of ulcerative colitis does not vary. Whereas in Crohn's disease there is a possibility that one may have Crohn's oral contraceptive. The ratio of odd is 1:4. Appendix being removed is protective in case of ulcerative colitis. Crohn's disease is not protective. In monozygotic twins, ulcerative colitis has a 6% concordance as against a very high concordance in case of Crohn's disease. So in case of Crohn's disease, the genetic plays a major role. When we talk of pathogenesis of these, so we talk in terms of two factors, exogenous factors and endogenous factors. The endogenous factors like intestinal epithelial barrier function, the immunity of the person, and the exogenous factors are the intestinal microbes. So all these two factors, when they occur in a genetically predisposed individual, his mucosa starts reacting against this, and that is called as chronic state of dysregulated mucosal immune function. So basically it occurs in a genetically predisposed and it is an immune reaction. So this picture shows you nicely that there is a barrier. You can see these are the intestinal mucosal cells, these are the bacteria. The barrier defect which leads to influx of the bacterial components, and then they elicit an inflammatory reaction in the form of production of lymphocytes. The current concept of pathogenesis of inflammatory bowel disease is basically it is an inappropriate immune response to the endogenous commensal microbiota within the intestine with or without some component of autoimmunity. See, one has to understand this definition, the concept very clearly. What it is an inappropriate immune response. Against whom? Against the endogenous commensal microbiota. All these microorganisms living in our GI tract, this is an inappropriate immune response against them within the intestine, and there may or may not be a component of autoimmunity with it. So genetics plays quite an important role here, which is stating that it is a polygenic disorder. 1/3 of them, the genes, they overlap loci on the different chromosomes in both ulcerative colitis and Crohn's disease, and there are genetic risk factors also seen in the other immune mediated diseases like ankylosing spondylitis, type 1 diabetes, psoriasis, so on and so forth. So when we talk of the genetic factors, so the primary genetic disorders that are associated with IBD are psoriasis, ankylosing spondylitis, and primary sclerosing cholangitis. So when we talked of oral tolerance, we meant that the normal mucosal immune system is normally unreactive to the luminal contents due to oral tolerance. We saw that. So, when there is some deletion or anergy, not energy, anergy of the antigen reactive T cells, there is induction of this CD4 T cells which suppresses the gut inflammation, and then now they secrete interleukin 10 and tumor growth factor beta. So what happens in IBD is oral tolerance is altered, resulting in uncontrolled inflammation. So that is the basic pathology. Oral tolerance is altered, resulting in an uncontrolled inflammation. So what happens? These bacteria are sensed by intestinal epithelial cells, the dendritic cells. Naturally they activate the T cells. Once the T cells are activated, they liberate inflammatory cytokines like interleukin 1, interleukin 6, tumor necrosis factor, and then the rest process is the same. There is activation of coagulation in the local blood vessels. There is fibrogenesis, collagen production, activation of tissue metalloproteases, and they all lead to the perpetuation of inflammation in an unregulated way. When we talk of exogenous factors, different pathogens have been implicated but not yet proved, like Salmonella, Shigella. They may trigger an inflammatory response which may go unregulated. We do not know. And very importantly, psychosocial factors are also supposed to play a very big role when we are talking of the inflammatory bowel disease. Please remember that, very important to understand. So with this background, we move on to the individual disease, and the first category you should know is ulcerative colitis. So the name itself is suggestive of the disease. This disease always involves the rectum. Where does it occur? It starts from the rectum and extends proximally to involve all part of the colon. That is 50 to 50% is rectum and sigmoid colon. In 30 to 40 cases, it may go beyond the sigmoid, and in rarely 20% of the cases, it causes total colitis. When it happens, we call it as then may go to the ileum, causing backwash ileitis. The pathology is in mild inflammation. The mucosa is red, erythematous, with a very fine granular surface. It is also called as a sandpaper type of mucosa, of a grainy, fine granular erythematous surface. Once the disease becomes more severe, the mucosa is hemorrhagic, edematous, and then ulcerations start happening. In long-standing cases, the inflammatory polyps they form, inflammatory polyps, pseudopolyps they are called. Then it may happen that in remission, that is when the person becomes normal, the mucosa may appear normal. And then last category is patients with very fulminant disease. There is toxic colitis or megacolon, ulceration, perforation, and so on and so forth. So this is just a picture, colonoscopic view, showing you how the mucosa looks like in case of an ulcerative colitis. You can appreciate these erythematous red areas of the mucosa. This is another black and white picture of pan-ulcerative colitis, where whole of the colon is being affected by this ulcerative colitis. Higher power view showing you this is picture showing you inflamed colonic mucosa. You can see that, and you can see this full of small polyps, I hope you appreciate these polyps. You can see these polyps here. Grossly you can make out Serpigenous ulcers, mucosal thinned out wall, ulcers, these are Serpigenous type ulcers, mucosal bridges. You can see this. I hope you appreciate this. Full of polyps. These are all pseudopolyps. The best part of ulcerative colitis you should remember is that the ulcers of these are only confined to the mucosa, and here is a very important differentiating feature between ulcerative colitis and Crohn's disease. When we talk of Crohn's, it is said to be a transmural inflammation as against the ulcerative colitis, where it is superficial type of ulcer. And if you go to the higher power, you will find that there is marked lymphocytic infiltration of the mucosa, and then the architect of the crypts are totally destroyed. So these are all chronic architectural changes in ulcerative colitis. You can appreciate the crypts are branching, irregular in size and shape, and lot of chronic inflammatory cells in the lamina propria. On the higher power cut section, this is what is the diagnostic feature. We call it as crypt abscess. You will see the neutrophils being infiltrating the crypts. In the clinical presentation, very important to remember, the patients will have diarrhea or rectal bleeding. Tenesmus is an important feature. Passage of mucus, a crampy type of abdominal pain, anorexia, nausea, vomiting, weight loss. On examination, one palpates the anal canal is tender, and you may get blood on the rectal examination. Very important features of ulcerative colitis. The complications are toxic megacolon. These ulcers may perforate, cause peritonitis, may cause strictures, and one should remember when we talk of incidence of malignancy, there are high chances of malignancy occurring in ulcerative colitis as compared to the Crohn's disease. So this is an histological picture showing you an adenocarcinoma of colon in a long-standing ulcerative colitis. Very important thing to remember, these patients with ulcerative colitis can occasionally have abscess ulcers involving the tongue, lips, palate and pharynx. So this is very important thing to remember. Abscess ulcers involving the tongue, lips, palate and pharynx. With that, we move on to the another type of inflammatory bowel disease, which was described first by Dr. Crohn, and that is called as Crohn's disease. As against ulcerative colitis, which is limited only to the rectum and some part of colon, Crohn's disease can affect any part of the gastrointestinal tract. Very important to remember. It can occur in the small bowel, basically a small bowel disease, and in the small bowels most of the times it occurs in the terminal ileum. 40 to 55% of the times both small and large intestines are involved, and 15 to 25% only the colon is involved. The important part is rectum is most of the times it is spared. Then another feature of Crohn's disease is there are skip areas in the mid of the diseased intestine. So you will find diseased intestine, you will get normal area, again diseased intestine. So this skip areas is one of the important feature of Crohn's disease as against ulcerative colitis, where it occurs through and through. You also can have perirectal fistulas, fissures, abscesses, and anal stenosis is present in 1/3 of the patients of Crohn's disease. It very rarely may involve the liver and pancreas. When we look at the morphology grossly, the involved segment is rubbery and thick. Now this happens because of edema, inflammation, fibrosis, and hypertrophied muscularis propria. If you do an X-ray, I will show you the X-ray. String sign is said to be positive. You can get skip lesions. The mucosa is very classically called as a cobblestone mucosa, and as against the superficial ulcers of ulcerative colitis, Crohn's disease will have deep penetrating ulcers, and fistula is a very common occurrence in case of Crohn's. So this picture shows you the appearance of mucosa, which is called as a cobblestone appearance. What is cobblestone? I'll show. This is the picture showing you the cobblestones. So the mucosa in case of Crohn's is similar to these stones. That is why it is called as cobblestone appearance. Then there is a tendency of the fat to accumulate at a place which is called as a sort of creeping fat. They may, because of to cover the perforation. So this is a slide showing you the normal bowel on the left hand side, and you see in the Crohn's disease the ileum is narrow and inflamed ileum. It is called as ileitis. This gross picture depicts the stenosis of the terminal ileum, and very beautifully you can see the string sign, very thin luminal contrast in the terminal ileum. So if you do a double contrast barium enema study, you will see marked ulceration, inflammatory changes, and narrowing of the right colon in patients. So this is a cobblestone appearance of the mucosal surface. Some more pictures, and you can very well appreciate that there is a abscess there. There is a narrowing of lumen, stricture formation, abscess formation, fistula is all are important features of Crohn's disease. On the outside, you can see that there is opening in near the anal canal. There is fistula. So you can also have enterocolic fistula of the Crohn's disease. So if you see the microscopic features, you find neutrophils in the isolated crypts. There is the architectural distortion in the form of blunting of villi, atrophy of the villi, metaplasia of the villi, and most important features you should remember when we are describing Crohn's, the inflammation is transmural. Please remember, again and again I am telling you the difference. The inflammation is transmural, and you can get non-caseating granulomas, whereas the inflammation in ulcerative colitis is mostly superficial. In the Crohn's disease, the whole thickness of the wall of the intestine is involved, and that is why it is called as transmural inflammation, presence of non-caseating granulomas, submucosal fibrosis, thickening of the muscularis propria, and stricture. So these are the deep penetrating ulcers you can appreciate here of the Crohn's disease. Just like deep knife fissuring. You can see how deep the fissure is extending here. And it's a transmural ulcer in the Crohn's, through and through. The ulcering is happening through and through. The whole of the inflamed mucosa, right from the mucosa to the serosa. This is called as transmural inflammation. And you can also get granulomas, but please remember here the granulomas are non-caseating. Where does this Crohn's occur? We have already seen they mainly occur in the ileojejunal, ileocolic and colonic region. So these are the three common sites where they can occur: in the ileum or ileojejunal, in the ileocolic and colonic. So when we talk of ileocolitis, the persons will have right lower quadrant pain, which is relieved by defecation. There will be weight loss, string sign in the X-ray, fistulae, microperforations. When the disease is mainly to the colon, colitis, we will get strictures and fistulae. And if the location is in the jejunum and ileum, persons will have signs and symptoms of malabsorption like anemia, hypoalbuminemia, hypocalcemia, nutritional deficiencies. So this will be the clinical presentations. The complications mainly are fistulae, and fistulae can occur in the duodenocolic. It can be to the mid-small bowel. Fistula can be rectovaginal. Fistula can be enterovesical, that is bladder and colon. It can be enterocutaneous, or you can get a perianal disease. Complications: serosal adhesions, perforations, peritonitis, intra-abdominal pelvic abscesses, perianal disease and obstruction. So nicely shown Crohn's disease and ulcerative colitis. So this was the clinical features. This slide shows you a nice depiction of Crohn's and ulcerative colitis, Crypt lesions, whereas as against the ulcerative colitis where the lesions are totally involving the whole of the colon, transmural inflammation, ulceration and fissures. Fissures are a feature of Crohn's disease. So I will revise again. Crypt lesions, transmural inflammation, ulcerations, fissures, non-caseating granulomas are features of Crohn's, whereas continuous colonic involvement, pseudopolyps, superficial ulcers are the features of ulcerative colitis. Patients with Crohn's disease also can have abscess ulcers involving the tongue, lips, palate. So if you want to summarize, we will summarize in this slide the features of Crohn's disease and ulcerative colitis. So when we talk of Crohn's, the site is ileum plus minus colon. In ulcerative colitis, it is colon only. Distribution: in Crohn's, the lesions are Crypt lesions, as against in ulcerative colitis, it is diffusely involved. Strictures form very early in case of Crohn's, where they are late in case of ulcerative colitis. The wall appears to be thickened in case of Crohn's, whereas thin in case of ulcerative colitis. Dilatation of colon occurs in ulcerative colitis. When we go under microscope, we will see a lot of pseudopolyps. Deep linear ulcers is a feature of Crohn's, whereas superficial ulcers is a feature of ulcerative colitis. Lymphoid reaction is very marked in case of Crohn's disease, as against mild in case of ulcerative colitis. Granulomas are present in case of Crohn's, absent in ulcerative colitis. Fibrosis is a very important feature of Crohn's disease as against ulcerative colitis. Fistula and sinuses again is a feature of Crohn's disease, not seen in ulcerative colitis. Malabsorptions, as is involved the jejunum, ileum, it is common. Malignant potential, both have that, but ulcerative colitis will have more tendency to form a cancer as against the Crohn's disease, and the response to the surgery is quite poor in case of Crohn's disease as against the ulcerative colitis. So with this we have completed the another important topic of inflammatory bowel disease. So we started with the diseases of esophagus, diseases of stomach, and now we in the diseases of ulcerative conditions of the small and large intestine. In practicals we will be talking of another lesion which may produce ulcers in the intestine, two of them, that is typhoid and tuberculosis. So when we are asked about the ulcerative lesions that are present in the intestine, typhoid, tuberculosis, Crohn's disease and ulcerative colitis are the main important entities you have to remember when we talk of these ulcerative lesions. And when we talk of inflammatory bowel diseases, we are mainly talking about ulcerative colitis and Crohn's disease. So this is a group of diseases which is chronic and which are related with the immunity. Please remember, it is an immune reaction, yet it is said to be quite mysterious in nature. Genetics play a role in causation of these two types of diseases, and also psychological and social factors are also important when we are talking of this inflammatory bowel disease. So next time we will talk about the malignancies of the colon and rectum, and so with that we will be finishing off with the lecture series of the GI tract pathology. Thank you. केलं बंद आणि याच्यात